Yeah. Please, sir. Yeah, start. Dr. Sanjeev.
So while I have gone through this video, what I have able to know is it is an integration of the NeuroManual therapy, neurodynamics, and the manual therapy, muscle myomanual therapy. So it is an integrative. Now here where we are giving the myofascial release while in the position. So this technique, so it is about giving massage kind of or nerve wrapping for the upper extremities. What I wanted to know, while we are doing for the lower extremities, okay, while we are doing for the lower extremities for the sciatic nerve, for example, or for the tibial nerve, so what should we do? Shall we go with the same kind of movement with the positions, or any examples which you would be able to give us? That would be.
I would like to first clarify that this course is for concepts. Okay, for you to understand actually what is the principles. Okay, we are not teaching techniques here. Okay, like for example, a demonstration shows upper limb. Obviously, it is applicable same way as the lower limb. Okay, you have upper limb tension test, which is upper limb neurodynamic test. Same way, lower limb we have the SLR test. If it is upper trapezius, example was shown in upper limb, it is the piriformis for the lower limb. Okay, so it all comes anatomically, it comes as the course in detail. Okay, but what we see for concept is there is a muscle, there is a nerve which is going in, and we are giving the myofascial release also, we are giving the neurodynamic treatments also, nerve mobilization also. So that means we can combine that same way for every region wherever the nerve is passing through the muscle. Okay, so that is the principle and the concept. So where you can understand the concept, you can apply it to every region of the body. Understood? Because nerves are nerves and they are same everywhere. Muscles are muscles which are same everywhere. But the positions will be different. The movement components will be different. Because it is the relation of the nerve to the joint. If the nerve is placed posterior to the joint, we will extend it. If the knee is. But if the femoral nerve, we will flex the knee. Okay? If it is sciatic, we will extend the knee. Whereas femoral nerve, quadriceps is important. Muscle. Because through that the femoral nerve is passing. But if it is sciatic nerve, hamstring is important. Piriformis is important. So that anatomical knowledge will help you, and the mechanics of the nerve changes from region to region, by which you have to devise your techniques. But the principles will remain same, even if it is masseter and trigeminal nerve. Okay? So it is going to be the same. But the technique will vary depending upon the anatomical and the mechanical behavior of the nerve in that region. Okay? So that is the main thing of all these concepts. That's why it's important to know the concepts, so that you can devise your own techniques for every region of the body. Okay? So going to next participant. On screen we have Deepak.
Good afternoon, sir.
Yeah, good afternoon. Yeah, tell me.
Sir, as describing you in the video, sir, what is meant by grade? Grade 1, grade 2, when you are doing an extension of the elbow. So I don't understand what is grade 1, grade 2, grade 3. So
I was showing the movements there.
yes, sir. Yes, sir.
I was showing what is grade 1. So if you do like that, it is grade 1.
Oh, this is grade 1.
For example, you want to mobilize any movement. Okay?
Yes, sir.
You want to mobilize a wrist extension. Okay? Wrist extension you want. You remember extension. Okay? That means from flexion position, if you are doing like this, grade 1. Because we have not yet reached the end of the range. Okay? This is grade 1 mobilization. If you do like this, means grade 1 mobilization. although we are not doing the extension. Okay. And this larger amplitude, if I do here, I'm not going to the end of the range, but still it
Yes,
is
sir.
grade 2 mobilization.
Yes, sir.
Okay. And then the next one is large amplitude like this. That is grade 3. And then small amplitude here will be the grade 4. Okay.
Okay,
So
sir.
that is, I want to improve extension. I can do it in grade 1, 2, then 3, and then to 4. The same way, neural also. In a neural position also, we can do the grade 1, grade 2,
Yes.
grade 3, and then grade 4. It
Okay.
actually stretches the nerve graded wise. Okay.
Okay.
First
Okay, sir.
day itself, we can't do in the end range stretch. Okay. Patients will not tolerate. So you have to do graded mobilization. Okay. Especially when you are stretching the nerve. Not for sliders. It's only for the tensioners. Okay. Where you actually create the tension on the nerve. Okay.
Okay, sir. Okay, sir.
Okay.
Thank you, sir.
And always remember one thing, that you don't tell that I don't understand that. Okay. You tell that in terms of, can you make me understand this? Okay. Can you
Okay, sir.
explain me so that I will understand? That is solution.
Okay, sir.
Don't tell in terms of, I am not understanding that one. Okay. That is problem. Okay. So don't focus on the problem. Focus on solution. So you talk like, can you explain and make me understand that one? Okay. So
Okay,
that
sir.
will be much better. Clear?
Thank you, sir.
Okay. The next part. So remember, neural mobilization is not strictly a passive technique. Okay. It is also active. Patient comes to us, we can ask, can you do the same movement what I am doing now? Okay. Do and show to the patient. Patient has to do active. Okay. And functionally in any position, no problem. Okay. By active itself, you will know, okay, patient, how much they are doing. Okay. Whether they can do it fully or not, or they are having any abnormal movements, okay, like trick movements. All this you can see that. Then make them to do in standing or sitting itself, you do it. Okay, that is in the functional position. You are trying to do an active assisted. It cannot be strictly passive in standing or sitting. Okay, you see that how the nerves respond, because immediately don't do the passive technique. Okay, one thing is you will not know how much to move, and you might worsen the patient's symptom. So always assess first how much the patient is doing actively. Okay, then you do passive. And if you are not able to diagnose by active, then you diagnose by passive. Okay, because nerve is actually a passive tissue. If the pain is there, I will move less. Okay, then you know that, oh, okay, is moving only this much range. Okay, so that means in passive, what I should do, I will do only very less movement, and immediately the pain is expected to come. Okay, I need not go to the full range. Okay, so I know the precautions. And the next thing is also the pain behavior. Okay, when pain comes, immediately patient will be like, okay, that means the spasm is also there. These all things will come in active. Patient who is having spasm, we will not do the tension test. Okay, because it will worsen the symptoms. So these all we can find in active. You will have to do in all the positions. Okay, it does not matter whether you do it in standing or sitting. One thing I will tell you, if a patient like a tennis player, okay, sports perspective, he's telling that after serving, for half an hour or 1 hour like that in the game, after that I am having pulling sensation in my arm, pulling. Okay, these patients, you make them lie down and then you check passive, nothing will happen, because their symptomatic position is functional standing position. And same way, in lying down position, you will maintain only for 10 seconds and you will come back, the neurodynamic test. But for them, you have to maintain it for 30 seconds or 45 seconds, because game, 1 hour of playing, after that only symptoms come. So you cannot just do a movement and elicit the symptom. You have to maintain that for a longer time. You have to stretch it maximally. Then the patient symptom might be provoked minimal. Okay? Or you have to give even contractions. Okay? And then the symptom will be provoked. Okay? So all this has to be added on in order to suit the symptom characteristic of the subject. Okay? So techniques can be added in any position. That is the difference between NeuroManual therapy and neural mobilization. Neural mobilization is a original, that concept, the technique-centered approach. But NeuroManual therapy is patient-centered approach. Which position the patient has symptoms. If a swimming athlete, okay, swimmer, the freestyle, is telling that when I'm taking like this, my arm is pulling sensation is coming when I'm swimming. Don't check them in standing, don't check them in sitting, don't check them even in supine or even in the prone on the plinth. I would prefer to check the patient inside the water. Okay. So remember, it has to reflect the symptom characteristic. Then only you are going to have a better evaluation and better test responses to decide the treatment techniques. Okay. And there is no harm in giving a home program where the patient is going to do active, okay, in front of the mirror. So that is also good. It is called as nerve gliding exercises. Okay. All of us can do that as daily flexibility also, nerves mobility. So that again is an active one which is performed in standing. You can perform in standing, you can perform in supine also the same thing. But the hemodynamics, blood circulation changes between supine to standing. Standing is more challenging, more as a progression. Supine, it is easy to perform for anybody. Okay. So remember this and accordingly prescribe the exercises. If it's a geriatric patient, you will tell them to do the nerve mobility exercises in supine. You will not tell them in standing or sitting. But if you want to improve their balance, the patient will be sitting on the physio ball. Okay. When they are on the physio ball, the vestibular ball, Swiss ball, that time they will do the neural mobility exercises. So that means you are training for balance. At the same time, you are training for the neural mobility. Okay. Or do the slump test. There's a slump test where the patient keeps the hand, slouches and then bends and then extends the knee. Okay. This slump test you can do above the Swiss ball, the physio ball. So that will enhance the core stability also and neural mobility also. So combine all this is the NeuroManual therapy. It's the manual therapy for the nerves. It's not just the nerve mobilization techniques. Beyond that, myofascial release also, a joint mobilization also, core stability training also, any exercise also. Everything can be combined in order to best benefit the patient. That is NeuroManual therapy. Beyond the combination of neurodynamics and neuromobilization, it's a patient-centered approach, a clinical approach, a registered approach of the AOMPT, founded in the year 2010. And to register NMT only, AOMPT was registered as a society. Okay. Afterwards, we registered the NMT as a clinical approach immediately within the 3 months. Okay. So that's such an important clinical approach.